Next will be a panel discussion on the significance of the gold practice guidelines. And for this panel discussion, I would like to invite Dr. Sonia Dalal. She is a senior pulmonologist practicing at Vadodara. Madam has been conferred the fellowship by American College of the Chest Physician, and she has been invited as a faculty at the chest conference by ACCP at Chicago. I will also like to invite as a panelist Dr. Atri Gangopadhyay. Sir is working as a pulmonologist at Ranchi. Sir has been pioneer of oscillometry in Jharkhand. Next, I will like to invite Dr. Hiren Parikh. Sir has a 15 years of experience in pulmonology and critical care and sleep medicine. Currently, he is working at Adikira Hospital, Vadodara. Then I would like to invite Arvind B. Dakshini. Sir is a professor of respiratory medicine department at Smimer Hospital, Surat. Sir has a total experience of 16 years. Sir has published multiple research papers. And lastly, I want to invite Dr. Amit Dave as a panelist. Sir has been working as a consultant interventional pulmonologist at Daya Madhav Hospital, Sterling Hospital, and Parul Hospital, Vadodara. Over to you, madam.
Thank you very much. Big shout of thanks to Abhishek, Samir, and the KIPS team for a fantastic academic feast. And I'm actually I take a basking in glory pride to be back to my alma mater. I'm from the 5th batch of Karamsad Medical College, and I always love coming back to this place. Can you just open this for me, please? And before this starts, for all the residents, to be very honest, this one is gold guidelines, this one. All ABPA need not be treated with antifungal. Please, this should be your take-home message, which Anand was continuously alluding to. So let's start with this. With me, we have my good friend, Etri, and we have my colleagues who are enterprising, Dr. Amit, Dr. Hiren, and of course, Dr. Arvind Dakshini. I'm sorry? Come. Okay. So before I start, a little preface on what a COPD is. And you people are from the Charotar area, which is the hub for the tobacco. So we all should be, we see a lot of patients of COPD everywhere in this part of the world. So COPD is basically a chronic disease which is progressive, and it has got increased trend in mortality and morbidity. India, unfortunately, has a second leading cause of death after the cardiovascular deaths. Around 30 million Indians are currently suffering from COPD. And currently, there are more than 100 million smokers in India. And 25 lakh Indians die in a year due to smoking-related diseases. The caveat over here is, which is very important for all of you to know, that most of the diagnosis of COPD, 1 in 3 COPD patient is not a smoker. Right? And 89% of the patients, most of us pulmonologists or most of us physicians would receive the patient of COPD only when they come in exacerbations. They directly don't come to you just with, simple consultation. And 1 in 2 COPD patient gets hospitalized for exacerbation at least once in a year. So to set the ball rolling, I'll ask Etri, so besides exposure to smoking, in India, if you see, we see a lot of patients who have not been smoking and they come in exacerbation. So what is the most common risk factor in your part of the world or in your country that you've observed in your practice?
Yeah, I come from Ranchi, Jharkhand, and it is a mining hub for the country. Very near from me, there are a lot of coal mines, underground coal mine and open coal mine. Like when I go to those areas, the soil over there is black. I have never seen white or yellow sand there. The sand over there black. The leaves over there, grass over there is black. So coal exposure, silica exposure is something very important in my part. Another thing, Jharkhand is a hilly forest area. There are places over there where LPG cylinders have not yet penetrated. And due to the indigenous preservation of indigenous culture and custom, there are some delicacies over there which are only cooked in biomass fuel. Means those delicacies cannot be cooked in LPG gas. So use of biomass fuel, coal mining, increasing urban air pollution, and bad treatment of asthma. Deny asthma initially, don't treat it properly, ultimately it leads to a airway remodeling. These are four things which I see regularly non-smoking COPD.
So, coming to the West, Hiren, would you like to add something to this?
Yeah, actually, other than the smoking, we are seeing many cases of occupational exposure. Like in very many industries, they are using chemicals. So chemical industries, factories, like there are so many across the Gujarat, so they have very high risk of developing COPD. Other than that, things nowadays there are been not the cigarette smoking, but the vaping or e-cigarette is also becoming very common among youth and youngster
But
people.
that would be smoking related.
Smoking
cigarette.
related
Yeah, that
only.
would be
Yeah.
smoking. So, we in our part of the world, we see a lot of non-smoking COPD. So, what are the causes? As A3
Yeah,
has.
non-smoking. Yeah, non-smoking COPD. Other than the smoking, you can include like childhood respiratory infection, low birth weight, premature birth. So that is also common. Early childhood, any major respiratory illness or tuberculosis can also later in the stage can develop into the chronic obstructive pulmonary disease. So these also we are seeing very common in our part of the India.
So that's precisely, I would urge each one of you to read the Goal 2023-24 guidelines, where they've given different definitions for the development of COPD, right? So a genetic, then it's smoking related, pollution related, and everything, low birth related, infection related, and they have defined each and every term. So I would urge you to go through the Gold COPD guidelines 23-24. So if you look at this study, which was by Dr. Salvi way back in 2009, if you look at the Asia Pacific region, India, incidentally has more 67% of the non-smoking COPD, where female is more than males. In India, you don't have much of female smoking, but they are more or less working on a biomass, what we call as chula. So we see a lot of patients working on a biomass, and they tend to develop COPD. If you look at the geography of the use of biomass exposure, if you look in the red, India and Africa tops as far as the use of a biomass fuel is concerned. So hence the odds ratio for development of COPD is same for smoker 2.5 and biomass of course 2.5. So in India, we have 65% of the patients having a burden of non-smoking COPD, where over here we see that the FVC, the capacity goes down, but there is a very less decline in FEV1, and there is more of a small airway obstruction. So this is a different phenotype. This is a completely different phenotype compared to a smoker's COPD, where there is no emphysema, but more of an airway and a small airway involvement. And most of the patients also have a high eosinophil who would respond more to corticosteroids. And hence, we'll probably come forward in subsequent slides, how to use inhaled corticosteroids in such COPD patients. If you look at the CT scan, this is a smoker's COPD where you see more of emphysema. You see, these are all centrilobular emphysemas. As compared to a non-smoking COPD, there is a mosaic attenuation. So if you look at, you can see a difference between white and black. So whatever there is white, there is a mosaic attenuation, and that shows that there is a more of an airway involvement, where there is a patient who has got a small airway disease. So Hiren, let me ask you this, and why is there an importance given to the precursors of COPD in the recent Goal 23-24 guidelines, and now how is it relevant in our practice?
Yeah, it's I would say that it is the one of the most important changes which GOAT guideline has mentioned. The precursors of COPD means the persons who had history of or risk factor suggestive of COPD, but the spirometric criteria does not show the typical obstruction, meaning FE1 and upon FEC ratio should be normal or more than 0.7. So these are considered as a precursor of COPD. The important is that because we should catch the patient in the early stage. For example, if the symptoms will include the patient has dyspnea, patient has chronic cough, sputum production, like chronic bronchitis type of picture. If you catch this patient early, the FE1 and FEC ratio will be normal. But if you have investigated further, it will show for example, diffusion capacity will be less than 90%. If you do the CT scan, it will show emphysema patterns. It will show some of the pattern like peripheral pruning of the vessels and airway thickening. So these patients would later on can develop into COPD. So this is the intervention where we should can done. Importance is that in our clinical practice, that if you treat this patient with LABA and LAMA, then it will not show any improvement. So the medication will be not useful in precursor of the COPD. Only importance is that we can avoid the development of COPD. For example, patient is smoker, you can ask the patient to stop smoking. And this most important useful of the precursor in occupational setting. So where person is working in particular industries, so doing a periodic FEV1 and periodic spirometry will be great useful so that we can avoid development of COPD in that patients. We know that FEV1 fall is approximately 20 to 40 ml per year. So if FEV1 fall is more than 40 ml per year in these patients, then we can consider this is will develop into COPD, and we can avoid developing the COPD either by asking a patient to stop smoking or changing the occupation. So that is the important thing.
So that's absolutely correct. So as he rightly said, this guidelines now have shown about the what is pre-COPD. How many of you are doing a pulmonary function test in your routine practice, please? And many a times you all might be saying that, you know, a patient is a smoker, patient comes with cough and mucopurulent phlegm, patient comes with wheeze or is very breathless. You know, COPD patient has a predominant breathlessness compared to less of a cough and all. And when you do a lung function, the FEV1 by FVC ratio is always normal, a post-bronchodilator reversibility. And FEV1 sometimes turns out to be less. That does not mean that we will not label that patient as a COPD. Of course we would. So that's the clinical. Or if you look at you get an HRCT of that patient done, patient would probably have, as I showed, a Penn-Acinar or Centri-Acinar emphysema. So those are the patients who are, you know, sort of a PRISM. PRISM is a preserved ratio impaired spirometry or a pre-COPD. But the patient is symptomatic, patient has a pre-test probability of a COPD, but his spirometry is not suggestive of a diagnosis of COPD.
Yeah.
So 40 to 50% of those patients in an eventual run, as you rightly said, needs to be monitored, and they tend to develop COPD. But why is it relevant in a clinical practice?
Yeah, I just want to add one more thing, that the FE1 FEC ratio should be more than 0.7 if it is normal. But in our patient, suppose the FE1 and FEC ratio is normal, but the FEV1 value is less, then the term has been used as a PRISM in our recent guideline. PRISM means preserve ratio but impaired spirometry value. So when the ratio is normal or more than 0.7, but the absolute value is low, then we can consider as a PRISM for the recent guidelines. This is important because many patients we are treating the COPDs, and many patients we miss as a COPD because the absolute criteria was 0.7 only. But now recent guidelines has been changed so that we can start the treating similar patient even if the ratio is normal, consider the PRISM values or the spirometric FEV1 values.
So how is it clinically relevant? What do we have to do? Why is it relevant that now we have to chase the PRISM patients, we have to chase a pre-COPD patient?
Because it will change the prevalence, the incidence of COPD, and whatever the data has been there in the guidelines, that also will be changed according to that.
Yeah, so this, I would like to allude this, a fantastic paper from JAMA which has been published in 2021, which has shown the they have compared the all-cause mortality, the coronary artery disease related mortality and respiratory related hospitalization as well as mortality in a normal patient, in a COPD patient, and in a PRISM patient. And if you look at it, PRISM patients have a more tendency to develop mortality compared to a normal patient, and hence we need to chase these PRISM patients. And as I said, 40 to 50% of this PRISM patient eventually would become a COPD or full-blown COPD patients. Arvind, coming to you now, let's go to the clinical diagnosis, clinical approach. So what is the medical history of a patient? What would you see into that patient, as a COPD in your practice include?
Clinical scenario, I would say that dyspnea is a cardinal symptom. All the patients of COPD will have dyspnea of different grades. Dyspnea is persistent, progressive, and patient will say dyspnea of efforts. When patient will do some walking or climb a stair, then he will breathe less. In differentiation to asthma, I think this is very important point, persistent and progressive. Asthma will have intermittent breathlessness. In between period, asthma patient may be absolutely normal when there is no bronchospasm. Second, I will go for second symptom is cough. Cough may be dry in almost 30 to 50% patient cough is presenting complaint associated with breathlessness. Cough may be dry or maybe with expectoration. In the chronic bronchitis patient, as per definition, cough with expectoration for more than 3 months in a year for consecutive 2 years is the definition of. So in that patient, cough is more prevalent. Third symptom, I would say chest tightness. Patient will say that I'm feeling that chest is tight. And some patient will also complain of wheezing, especially wheezing at night or wheezing after exertion. Chest tightness, I would suggest to be more aware or to rule out comorbidity, cardiac breathlessness also along with that. Some patient will present with the recurrent cough and cold, especially in the winter. They will call as a winter cough. Then some patient may directly come to us in very severe stage and or in exacerbation, cough with expectoration, with hypoxemia, with need of oxygen. Sometimes we got patient from other department. Patient is unaware of that. Sometimes cough maybe patient is taken as a smoker's cough. Then may patient present with the hernia because of excessive cough. It is may present directly to the surgeon and they refer back to us. Sometimes patient also may have cough syncope also. When very continuous coughing is there, then there
So
may be
your
also
point is
cough
well
syncope.
taken. Yeah, your point is well taken on cough and everything. You mentioned about cold. So would you like to differentiate between asthma and COPD in those patients? When you say about cold, frequent
asthma-
cough, would you like to differentiate an atopic lung disease versus COPD in such patients? Amit?
So basically, asthma and COPD is a main differential diagnosis, and we need to see atopia. If asthmatic patients comes to you, they will have some kind of allergic component. Maybe their eosinophil counts will be high, their IgE level will be high. They have intermittent episodic dyspnea in a clinical presentation. COPD will have a more of persistent, less atopia, and they exacerbate more of cough or dyspnea rather than intermittent episodes.
Correct. So,
Yeah,
then coming to you.
along with that, asthma person usually they have family to asthma. They have the symptoms will be starting from early childhood. Compared to COPD, the symptoms will start from the late adulthood also. And then asthma patient, you will find some of the allergic manifestations like allergic rhinitis, eczema, dermatitis. So you should check for that thing.
Okay, all right. So coming to Amit, so now we all know that we are in the world of phenotypes, right? Because one patient, one size does not fit all. Everyone behaves differently. So we are in a world of phenotype. So after confirming the diagnosis via spirometry, where here we are looking at a post bronchodilator FEV1 by FVC less than 0.7, right? And patient is falling into mild, moderate, or a severe category. Now, what are the other parameters, or what are the other clinical criteria that you will consider before initiating the treatment?
So if we are first diagnosing, if it is a stable COPD, I would say, first do ABE assessment by clinical, spirometric, and past exacerbation, if any. So do a MMRC gradation, get your spirometric gold 1, 2, 3, 4, get previous exacerbation. Previously it was a A, B, C, D group of a stable COPD. Now it's ABE. So A is nothing but grade 1 or 2 MMRC 0 and 1. B is 2 and 3 and no exacerbation at all. E compromise 1 large exacerbation or 2 mild to moderate exacerbation. So ABE assessment is most important before starting any treatment. Apart from this, if it is a first diagnosed COPD, I would like to do a imaging modality, at least chest X-ray, or if possible, HRCT to see the predominance. So now, as madam said, the phenotyping is the something where we are going beyond the just pharmacological management and we more into intervention. So which kind of phenotypes in COPD patient, whether it is chronic bronchitis, whether it is emphysematous, so which part of lung is predominantly involved. centrilobular emphysema, panacinate emphysema, low predominant, or mucus predicting chronic bronchitis. So imaging modality is more important. Another, I would like to see a diffusion lung capacity of that particular patient for further evaluation and lung volume.
So
These are
Amit,
the
would
basic.
would you need a imaging and diffusion and everything just to start a medical therapy?
No. I am just talking.
So the
which,
only thing is, I'm just talking about that the
ABE
moment
assessment
exactly.
to
ABE,
start the
exactly.
treatment. Yes.
So the take-home message is very clear. The moment you're done with spirometry, you just have to look at the MMRC or a CAT score, and you have to look at the history of exacerbations. Now, and you also look at some eosinophil count. The reason being to take a decision of starting an inhaled corticosteroids, because in COPD, upfront inhaled corticosteroids are not recommended at all. It's always a LAMA or a LABA and a LAMA combination which has to be started. So this is what, just as a primary assessment to start a therapy. Once the patient is not improving with that, then as Amit said, that you get a CT scan done and you get other modalities done, right? So the take-home message is very clear. Clinical guideline, the questionnaire, exacerbation history, and spirometry. These three are enough to put you at A, B, and E, right? Exactly. So A3, what's your take on this goal 2024? There has been a great paradigm shift, and the people have been, talking about that ABCD to ABE. So tell me what prompted them to come up with this supplement to change over from ABCD to ABE?
The advantage or the problem of using the internet or growing up in the millennium is that you people go very fast. That earlier you used to go A, B, C, D, but now no, you have internet, you can go fast from A to B to you can straight away go to E. So the main thing, importance of E is risk matters. If there is high risk, then it does not matter whether there is low symptom or more symptom. High risk is high risk. So C and D was merged into E to make everyone understand that high risk is high risk. What is the meaning of low symptom, high risk? That is one thing, very important thing. Another thing about this guideline is they have been very vocal about where not to use steroid ICS, where to use steroid RCS. Earlier people used to have the dilemma that देना है तो सबको दे दो और जहाँ देना है वहाँ मत दो. But now very beautiful with that blood eosinophil parameter, they have clearly demarcated that where ICS will not help and where ICS, if needed, you start it early. These are two very, I would say, practice changing shifts in the guideline. And third thing, in asthma, we are talking about phenotype since a decade or more than that. If there are two primarily obstructive airway disease, one is asthma, one is COPD, then why not phenotypes in COPD? This guideline, using those beautiful terminologies in the first 3 or 4 pages, have given the importance of understanding phenotypes in COPD, that one size will never fit all.
So basically, more importance has been given to frequent exacerbators, right? This is the take-home message, because there is a decline in quality of life, decline in lung function, and increased mortality. So C and D was quite confusing. So what they have done is they have clubbed into E only because they wanted to give more importance to exacerbators rather than the symptomatic patient, because anyways in symptomatic patient you are going to give a LABA and LAMA, correct? All right. So let's start with a case. This is a 62-year-old male, Mason by progression, brought to the clinic by his son. He has shortness of breath and cough since 2 years, progressive symptoms, worsened over last 3 months, breathlessness on climbing one flight of stairs, cough is accompanied with copious greyish sputum, expectoration. He is an ex-smoker with 25 BDs, that means a very high smoking index, every day for 40 years, and he had quit just 4 months back. So now, right, this is the history. Amit, this is for you. Now, this is the world of phenotyping, right? We need to phenotype this patient. How would you confirm that this patient has a phenotype of a chronic bronchitis?
It's very difficult on only history. Usually classical says that chronic bronchitis is chronic of more than 3 weeks and difficult to spit out the sputum. So 3 months per 2 consecutive year is chronic bronchitis as we define. In your patient, the patient has a more of dyspnea rather than
no, has a cough with
cough.
grayish expectoration
Sure.
most of the days.
So most of the, so if it is a consecutive 2 years, it's a chronic bronchitis, and dyspnea, which is persistent increasing, and so it is a emphysema. So this is chronic bronchitis.
So very important in this supplement, they have written that, you need to, in the absence of other conditions, so you're ruling out all the other infective conditions like bronchiectasis. So this is where your CT scan would come into picture, right? This is where the, other investigations would come into picture. The IgE,
IgE
ruling
and
out
all that.
ABPA. Right? Because
Yes.
as Amit, Anand rightly said that ABPA is possible even in a COPD patient. So this is where, so you rule out all the cases,
All the
and then
other-
when you get a mosaic attenuation or a, peripheral pruning of the bronchi, this is the way that this is the phenotype of a chronic bronchitis.
Chronic bronchitis.
All right? Okay.
Yes.
So, Arvind, what patient profile would you consider for a diagnosis of COPD?
First of all,
And since we are running short of time, let's
as
be
you all
very
know,
fast
smoking
here.
is a main risk factor. So all the current smokers, part smokers, passive smokers, the person in which when he in pregnancy, if mother has done smoking, passive smoking, all the patient. Then I would also add the biomass exposure as indoor cooking. Sir has rightly said that custom cooking. Then many industries which have fumes, irritant gases exposure, workers, they should be screened regularly. Then other post-tuberculosis, patient has history of AKT before 5 year, 10 year back, and have starting
That
complaint
we
of
con-
breathlessness.
that we have
Post-tuberculosis,
considered
HIV.
into history.
Okay.
So profile, it would be cough, breathlessness, and sputum production. That's the only three profile. When you rule out the other respiratory infection, that's the profile that you are considering for COPD,
Okay.
right? Because all those things we have already taken into history. We are way beyond history now. We are, solving the case, right? Hiren, would you like to add something?
Yeah. The most important thing is cough, sputum production, and amount of sputum and the purulent of sputum. So that
Perfect.
is the
Perfect.
important thing.
Perfect. Yeah. So this guy's CAT score is 25. I'm sorry, I'll be a little fast because this is giving me tensions now, the timer. The total score is 25. MMRC is 2. Now this is an open question to you, right? The patient's, what is the drug of choice? Patient has not come in exacerbation to you, right? Would you write a LAMA? Would you write a LAMA or LABA? Would you give an ICS plus LABA or LAMA? Or you will just start with oral methylxanthins? Audience? Would you, this patient comes to you. Patient has got an MMRC of 2, CAT score of 25. He is symptomatic. He is unable to climb stairs. He has cough with mucopurulent phlegm. He has a predominant chronic bronchitis sort of a thing, right? Normal eosinophils at the moment. Let's take like this. Where would you put it? Where you put it in A, you will put it in B, or you will put it in E? Where will you put this patient? Where will you put this patient? Exactly. So what would you start
Lama.
in this patient? You would start a LABA and a,
Lama.
right? So this is how you should approach a COPD patient, right? This is the patient. Okay, so this is how, modified initial pharmacological treatment is there. If you have group A, you can start a bronchodilator, either a LABA or a LAMA, but predominantly a LAMA, right? Group B, you give a LABA or LAMA. In group E also you give LABA, LAMA, but if the patient has got frequent exacerbations or if the patient's eosinophil counts are high, those patients you add inhaled corticosteroids, right? They are very, very clear this time that you cannot give inhaled corticosteroids with LABA. If the patient is very symptomatic and eosinophils are high, you always give a triple drug combination. So, Hiren, what's the ideal dose of glycopyrronium when you are using it in?
Glycopyrronium is a long-acting anti-muscarinic agent. It is various trial has been done for different dose and different combination also. Basically, to just straightforward answer, monotherapy when you are using then 25 micrograms twice in a day or 50 grams once in a day, it will not make a difference. So usually we recommended the either of the things. When given as a monotherapy, then 25 micrograms in a twice in a day, little better in the terms of the symptoms. Nocturnal symptoms and early morning symptoms are better with the 25 micrograms twice in a day compared to 50 micrograms once in a day. When you combine with the formoterol or indacaterol. So then, because formoterol it's a twice in a day combination, so we prescribe 25 micrograms glycopyrronium with formoterol, and indacaterol is a once in a day. So usually 50 micrograms of glycopyrronium with 110 micrograms in indacaterol once in a day is a ideal combination for glycopyrronium.
Yeah, so these are the studies which shows that 50 microgram is as good as the dose of a tiotropium, because then the trough FEV1 was much improved. And as you rightly said, you know, when you look at the nighttime symptoms, if you give a 50 microgram OD, there is a dip. And that patient might develop symptoms. So 25 microgram BID would be better to take care of nocturnal symptoms, right? Okay. So A3, COP, in these guidelines, they have said use a single therapy. I mean, you use a single inhalation therapy. And why a great weightage has been given to those patients?
Number one, compliance. COPD patient does not have only COPD. Coronary artery disease hoga, hypertension hoga, diabetes hoga. If female person in the 50, kuch gynae hormonal issue hoga. So that person will need multiple doctors, multiple medicine. So your medicine, how much minimum you can give, that will give patient confidence to come back to you again and again. This is a lifetime thing. ऐसा डॉट्स जैसा नहीं है कि 6 महीना खाओ बंद करो, लाइफ टाइम थिंग है. सो द मिनिमम पिल बर्डन और मिनिमम मेडिसिन बर्डन बेटर. सो SIT number 1, compliance, improves adherence, reduce exacerbation.
Perfect. Perfect. Let's go to case 2 now. This is a 53-year-old male, ex-smoker, 20 pack years, sedentary worker, hypertension, dyslipidemia, comes in an exacerbation. Acute onset, breathing, breathlessness, cough with mucopurulent phlegm, most of the time since last 4 days, and a fever. He's fatigued, tired, history of 2 hospitalization due to exacerbation and multiple ER visits. Normal echo, severe pulmonary hypertension, grade 2 diastolic dysfunction. Hiren, how will you approach the fever? How will you treat worsening cough and breathlessness? We are talking about lung attack now.
Yeah. So the patient is clearly shows in the respiratory distress. So definitely will require admissions. So during admissions, because the patients are repeated admission, so I would other than the COPD exacerbation, probably during the admission we need to rule out other things which can mimic COPD. For example, pneumonia, congestive cardiac failure, and pulmonary embolism. So that we need to simultaneously rule out during the other investigation. Basically, when you admit the similar patients, we need to see that when you give the oxygen, the saturation should be approximately 88 to 92%. So when many times we are seeing that in emergency, when patient will come, the medical officer or nursing staff will try to give maximum oxygen to keep the saturation level 99-100% similarly. So that we should avoid in any patient who come into emergency, particularly COPD patient. Similarly, when you admit the patients, you need to give oxygen other method also, like high flow oxygen also should be given. You need to see the patient closely, because COPD patient, if they deteriorated, you need to see that where is this mental status, whether this patient is alert or not, patient has any flapping tremor or not, patient is not improving, and patient dyspnea counts is persistent, accessory muscle of working is there, and patient's hemodynamically is not getting stable, then you need to quickly change to the non-invasive method, like non-invasive ventilation also should be considered for this patient. Antibiotic, when the patient has the sputum production increase or purulent sputum, then you should consider antibiotic. And choice of the antibiotic depending on previous patient, any histories are there or not. Usually in simple, there is no any chances of developing of resistant infection, then amoxicillin, clavulanic acid with macrolide
So
should be
that's
sufficient.
antibiotics according to their policy. I'll be requesting all the panelists to be very, very short and give the crisp answers. What category of gold this falls into? A, B, or E? Fair. So what would be your discharge medication? A triple drug or a double?
Triple drug medication.
Perfect. All right. Fine. Now this patient is treated as group E COPD. He has core pulmonary, as I said, pulmonary artery pressures are very high. He is on a high dose of ICS, LABA and LAMA. Oral acetylprophylline, spironolactone plus torcelamide. Again comes with exacerbation, right? Amit, what will you do now?
We need to treat this exacerbation and evaluate for long-term oxygen therapy or an IV therapy and triple drug.
Triple drug is already there. So what would you do? He was a
add
smoker.
on-
He was a smoker.
Smoking cessation, number 1. Number 2, add on long-term oxygen therapy or evaluation for NIV.
Exactly. So if you look at the gold paper, they have given you a follow-up treatment and they have given you two pathways. One is if the patient is very much symptomatic, if the patient is exacerbator. Now if the patient is exacerbator already on a triple drug combination, there is a, and he is a smoker. So there is a role of addition of azithromycin, right? Along with, as you rightly said, the other parameters like rehabilitation, NIV, LTOT, vaccination and everything. So giving an azithromycin, what would be the dose that would you recommend in this patient? He's a smoker.
500 milligram thrice weekly.
250 alternate
Or
day for
alternate
6
day.
6 months, but you will have to check the hearing as well as the cardiac status as well. All right. Case 3, I'll be very fast now. 60-year-old female, housewife, shortness of breath, cough, gradually progressive, cough, no hemoptysis, no weight loss. Now, she has a history of biomass fuel exposure for 20 years. Incidentally, she is also allergic to multiple drugs. She has urticaria and hives. Her breathlessness and cough increases with change of season. So here we are dealing with a phenotype where the patient is chronically asthmatic, uncontrolled, progressing to COPD. Now we don't have a terminology called ECOS. It is completely out. So it is COPD concomitant with asthma, right? So for you, Arvind, in which clinical scenarios will prompt you to straight away use inhaled corticosteroids in a COPD patient?
You said the COPD concomitant with asthma. Then another patient, if I would go for CBC and eosinophil count is absolute eosinophil count greater than 300 and patient has history of exacerbation, then we should add steroid. In guideline also 100 to 300 we can also add the corticosteroid, but we should keep watch on because we all know the inhaled corticosteroid have the risk also to increase the LRTI, pneumonias and oral candidiasis.
So strongly favors eosinophilia, frequent exacerbators and concomitant asthma. These are the only three in this phenotype we use inhaled corticosteroids or use a triple drug combination. All right. So what are the non-pharmacological interventions for your COPD patients?
So I already mentioned long-term oxygen therapy, vaccination, smoking rehabilitations, and pulmonary intervention. I would like to say they are in pipeline. Few we are doing bronchoscopic lung volume reduction surgeries and good cryo. We just had a 30-second talk prior this panel that cryo spray therapy we are doing for chronic bronchitis. Paper is in pipeline, but we'll see the fate.
It's not approved in India, rheoplasty.
No, not yet.
Probably
not yet.
it's going to meet the same fate like bronchial thermoplasty. So let's
Probably
not discuss
yes.
about rheoplasty now.
Yeah.
Okay. Athri, this is for you. You coming from a place, right, where you have a lot of patients who come from the remotest places, and when you want to give them a rehabilitation, how do you reach out to them? How do they reach out to rehabilitation centers? It's not possible. So what are the plans that you give it to your patient for rehabilitation?
Prior to COVID, I was very much against this telemedicine. During COVID, I would talk about a personal event, very short. My wife was having difficulty conceiving. The gynae doctor told us you need to lose weight. One gym lady, she used to, that was COVID, lockdown. That gym lady used to do classes for my wife over WhatsApp video call. 18 kilo my wife lost in 3 months and we became successful. So that made me a fan of this telemedicine. So all my COPD patient at my center, they are given some exercises and they are giving the number of that physiotherapist over there for video exercise once a week from your home along with a diet chart. It is successful. You can also try it.
So the take home is advise rehabilitation in every patient, whether they have an access to the place or they can do a teleconsultation or they can go once in a week and they have a strong follow-up, right? Now this is, Abhishek, I would appreciate if you give to the audience. This is now for audience, okay? Let's start with a case and I want all the audience to participate in this quiz. This is patient X who presents with disabling breathlessness. He's 55 years of age. He's a male. He's a smoker with 10 pack years of smoking history. Echo is normal, renal function normal, HbA1c is normal. What would you do next in this patient? The pre-test probability is COPD. What would you do next? Pulmonary function test. Great. Right? According to the goal 23-24, you do a pulmonary function test where you look at the post-bronchodilator reversibility of FEV1 by FVC less than 0.7 and then you grade them as mild, moderate and severe. right? Okay. So his spirometry result is post bronchodilator FEV1 by FVC 0.52. So does he fall into the COPD criteria? Yes or no? Okay. And his FEV1 is 50%. That means he is a moderate obstructive, right? CAT score is 8. And he has one exacerbation in past 1 year, which was treated on OPD basis, right? So what will you treat, how will you treat this patient? LABA, LAMA or a triple drug? CAT score is 8. CAT score is 8 and moderate obstruction. He falls into which group? A, B or E? He falls in A, right? So you can start with a LAMA, right? Now, you know, this patient comes to you after 2 months and he is complaining of symptoms, no exacerbation. Then you have to follow the pathway of continuous symptoms, not a exacerbation, right? Here his post bronchodilator reversibility is 0.68, FEV1 is 56% percentage, eosinophil counts are normal, right? And so what would you do next? Which category he falls in now? A, B or E? So this is what you follow. He goes into the dyspnea, he falls into the dyspnea cycle, right? So he is on a LAMA. What would you do now? Exactly. So now he goes into, from A he goes to group B, right? Our next follow-up after 8 months, he has increased his rescue inhalers and he comes with frequent exacerbation now. So that, you know, the follow-up, he falls into now an exacerbator category. His post-bronchodilator reversibility is 0.52. Eosinophil count has gone from 88 to 270 and he complains of severe cough and breathlessness. What would you do now? So what would you do now? This is, you would add a triple drug combination. So there you add a LABA, LAMA and an ICS. So this is how you approach a COPD according to the Goal 23-24 guidelines. And I take privilege in inviting all of you to the Goa FIST, academic FIST. And this is on 19th to 21st of July 2024. And we also have an abstract submissions, all the residents. The last date is 1st of June. I would urge each one of you to submit your abstracts as well. I welcome you all to Goa as well. Thank you very much.